Okay, Andrea, I think we can start. I'm going to give a welcome to everyone to this webinar. Once more, the European Forum for Primary Care is trying to do a webinar each month. So this time it's going to be about health inequalities among the migrant population. And we will have Andrea Canini, Tupa Chalistan, and Julien Artigny with us today, talking us about the cases of France, Turkey, and Italy. They will introduce themselves better in a bit, but I just want to give you some technical advices because we're going to be, or you are going to be able to make questions to them. So if you have any question, you can actually type the question in the chat box. And I'm asking, please, Andrea, Tuva, and Julien, remind this to the attendees because maybe some people connect later, but for the people right now connected, you can type them there, and I encourage you to do it along the presentation and not at the end because we will be collecting some of the questions, and yeah, we will post them at the end to them so they can answer you better. Basically, I'm going to give the floor to Andrea, which is going to start, and I'm going to ask you, Andrea, if you can actually turn on your camera and present yourself so that people actually can see who you are a bit, if possible. There it is.
Hello, everybody. Are you okay? Hello, everybody. My name is Andrea Canini. I am a family doctor and the EFPC coordinator. I am also a member of the Young Leadership Network of the WHO. And I worked since 2 years with migrants population in an ambulatory for volunteer healthcare professional in my city, which is Bologna in Italy. And okay, I think that you can interrupt me whenever you want to make question, and I will very happy to try to respond to them. And I will begin my presentation now. So let me pass to the presentation. Here I am. Okay. So the title of the presentation is Migrants' Health in Italy, from Right to Health to Security Decree. And first of all, we should focus on term, asking ourselves who a migrant is. The International Organization of Migration defines a migrant as any person who's moving or has moved across an international border or within a state away from his habitual place of residence, regardless of his personal legal status, whether the movement is voluntary or involuntary, and what the causes for the movement are. Despite these nice and comprehensive definition in migration statistics, is not uncommon for different mobile groups to be classified together as immigrants or categorized solely by nationality. But people frequently fit into multiple categories or change their migration status over time and circumstances. So from a public health policy perspective, an important dichotomy is between documented versus irregular and forced migrants. This aspect is extremely important because it permits me to stop focusing on migration as a politically constructed phenomenon. Thus, the European Union, on one hand, creates this fantastic Erasmus program, and I did it, for example, to attract and permit mobility of qualified students and future workers. And on the other hand, it forces people to travel under very extreme, often fatal conditions to reach the European border. When we start looking to migration under the health lens, we can consider that migration is a complex experience influenced by factors that can stem from the pre-migration phase, including, for example, wars or climate change catastrophes, the migration phase, which is, especially in the case of the Mediterranean route, characterized frequently by tortures and exploitation in the Libyan camps, the post-migration phase, and eventually the return phase. Internationally, policy making on migration has generally been conducted from policy sector silos that rarely include the health sector and which often have different, if not incompatible, goals. And the discussion on global migration governance and global health governance expand, it will be very important for policymakers to engage in cross-sector coordination and move beyond narrow protectionistic policy approaches. Here in this slide, we can see two Italian right-wing journals trying to convey the idea that migrants bring diseases with themselves, and the title of the lower quadrant states, indeed, after misery, they are bringing diseases. There is also a widespread misconception, both in the Italian and the European population, that migration could represent a threat toward host countries in terms of infectious diseases and the risk of epidemic. What actually public health data show us is that migrant population represent generally a better health status than native population. This has been referred to as healthy migrant effect and can be partially explained through different facts, such as the fact that people need to enjoy good health in order to be able to bear the air migration travel, the fact that migrants are generally of young age and have good working capacity, or the fact that when they get sick, they may be willing to go back to their own countries. This is called also the Salmon bias. What happens in reality is that the healthy migrant effect is lost after long-term residence in a host country that leads to health deterioration among some immigrant groups as a result of poor living and working condition. This has been referred to as the exhausted migrant effect. Worth noting also is the fact that healthy migrant effect is not seen for refugees, which on the contrary can be exposed to specific health threats due to our pre-migration and migration condition. These slides show us very clearly the disease burden that affect migrants before, during, and after the migratory process, with a huge prevalence for the post-migration process. And as we can see, the 80–90% of the diseases is actually acquired in the host country. Moreover, based on figures available in published literature, standardized mortality ratio estimates tend to be lower in migrants than in the European host population for all-cause mortality, neoplasm, mental and behavioral condition, but higher, for example, for infectious and external causes, or, for example, blood diseases. What about Italy? So in Italy, the Article 32 of the Italian Constitution states that the Republic safeguards health as a fundamental right of the individual and as a collective interest, and guarantees free medical care to the indigent. And consequently, any foreigner present in Italy, regardless of his or her status, is entitled to access public health services. To give you a snapshot of migration inclusion in the Italian society, I hereby show you the result of the MIPEX Index, which is a questionnaire that measure equitability of policies relating to 4 issues: migrants' entitlement to health services, accessibility of health services for migrants, responsiveness to migrants' needs, and measure to achieve change. So we see that from this picture, frequently migrants have same conditions of inclusion to the general population. And if we want to look to the result, it seems that in Italy, the access to healthcare system for migrant population is fantastic. But actually, reality is far more complicated. In general terms, we can make 2 big distinctions: access to health system for documented migrants and for undocumented migrants. The right to medical assistance for documented migrants, such as asylum seeker, is acquired at the moment of the registration of the asylum request, but very often the exercise of this fundamental right is hindered and severely delayed depending upon the attribution of the tax code. And this means that in this period, migrants have only access to emergency care and essential treatments. And once registered, they are provided with the European Health Insurance's card, whose validity is related to the one of the permit of stay. And the registration entitles the asylum seeker to choose for a general doctor. He has, moreover, special medical assistant to a general doctor or a pediatrician in case of young people, midwifery and gynecological visit at the family counseling, and free hospitalization in public hospital. Asylum seeker with an expired permit of stay have no guarantee of access to non-urgent sanitary treatments for a significant length of time due to bureaucratic delays. And in the case of an undocumented migrant, they only have access to urgent and essential care. But as long as we consider health as a complex phenomenon and not just under a biological or from a healthcare perspective, and we move toward a more integrated perspective, such as social determination of health, we have to consider that multiple conditions must be taken into analysis. So what you see here is not a camp in North Africa, is rather an Italian city called Rosarno, which every year many migrants living in such very poor condition are going, especially in the period of tomato or oranges picking, to find a work. And if we want to take into analysis a broader context, we also have to think about societal issues, for example, racism in society, which is in the last year on a big rise, and for example, political, institutional racism, which after the election, for example, of the Lega Nord party is actually on the rise. So hereby I show you the diagram of social determinants of health, and I've shown you, for example, living condition, working conditions, social and community factors, and governance condition to try to depict how complex the issue of migration and healthcare is. Despite migrants enjoy generally a better health than the host population, we also face important inequality, especially in some subsets of diseases. For example, here we see that in sub-Saharan African males, we have a 5-fold increase of hemorrhagic stroke. There is a general higher prevalence than a native population in important diseases such as diabetes or myocardial infarction, especially if we consider the case of South Asian population. Generally talking, the presence of chronic disease is similar or even a bit less than the host country. So just to conclude my presentation, I want to say you goodbye with the two pictures of hope. Here you see the picture of a city whose mayor has been candidated for many important international prizes for migrant employment. And here you see the presentation, the image of the ambulatory where I'm working as a volunteer doctor to try to assist and give the right to help to undocumented migrants. Thank you.
Thanks, Andrea, for the presentation. I think there is already a questions, but I'm going to be collecting them. So once more, I'm going to remind you that you can actually type your questions in the chat box, and at the end we will just post it for you, and you can start thinking about the answer that you want to give. But now I'm going to give the floor to Tuğba. So please, Tuğba, welcome.
Hi everyone. I am Tuğba Çalışkan from Turkey. I'm a junior doctor in my 3rd year. I am the liaison person of EFPC in VDGM. And also I am working with Andrea and Diana in U and EFPC group. So I want to talk about how it is going on in Turkey. As Andreas said before, the refugees are not only Syrians or Arabic or the others. There are lots of people there, but as Turkey, after the war, we have to deal with the Syrians, and we have to take attention to them. And as you know, we are the first stop country. Please, Andrea, next. There are currently 21.7 million refugees worldwide, and among them more than 5 million who have fled more than 6 years of war in Syria. Next, please. And you can see that most of them are female, and among age range is 18 and 59. Next, please. Turkey hosts over 2.9 million registered Syrians, and the majority of them live in urban areas, with around 260,000 accommodated in the 21 government-run refugee camps. We have 21 government refugee camps before, but nowadays we started to close most of them because Syrian people started to adapt to live in Turkey, and they started to have a job, they started to earn money, and they get used to live in Turkey, and we don't need these camps nowadays. Next, please. You can see the camps area in the map. We had 21 camps in 10 provinces in Turkey. The marketplace is the city that I am now living in. We had 2 camps in Mardin before, but now we closed them because in Mardin there are Kurdish people, Arabic people, and also Turkish people. And when the Syrian came after the war, they can easily speak with them Kurdish in Arabic, and they easily get used to live in my city. So now we don't have the camps. Turkey spent $25 billion on helping and sheltering migrants. Next, please. As many as 177,000 babies have been born to Syrian refugees in Turkey over almost 6 years. And after that, Turkey added new vaccines to vaccination calendar to poliomyelitis and the measles. For example, in Mardin last year, we had 3 campaigns for the vaccinations for Syrian babies. It was like a detective case because we don't have their exact address, we don't have their numbers. So from street to street, we look after them and we find them and make the vaccinations. And the other numbers is the numbers of our camp in Mardin. We had vaccinated 29,000 babies, and we gave them newborn follow-ups, infant follow-ups, child follow-ups, and also we look after chronic disease. Next, please. And today I really want to talk to you about the Sıhhat project. It's an interesting project for me because we gave the we gave primary health care to the refugees with Syrian people. We took the Syrian doctors and medical staffs to education for 6 weeks, and then we try to teach them the healthcare system in Turkey, how it is going on in Turkey. We try to adapt to them, and then we made some specialized health centers to provide medical services for Syrian refugees. Nowadays, we have 65 places for them, and also we had 7 education places in different provinces. In Istanbul, Ankara, Izmir, Mersin, Antep, Urfa, and Hatay, we have education places. The project is very important because we made all the materials in Turkish and also in Arabic. We also teach the medical staff and the doctors, Syrian medical staff and the doctors, a little bit Turkish that they can use in their daily life. And now they are working like a primary care doctor in Turkey. Next, please. And after this 6 years period, we made some questionnaire for our colleagues, and I want to share the answers with you because they have some concerns about the situation. One of them says, I feel helpless when my refugee patient doesn't know speaking Turkish, English, and I am afraid of misdiagnosis. One of them said, I don't have enough time for dealing differences. I have more than 100 visits in a day, except other duties. In Turkey, per family medicine doctor, there are 3,000 patients. They have to look after 3,000 patients and more. So when the refugees came after the war, they didn't live in camps so long. They firstly split near the country, and now they are living all over the country. And as I told before, we have some healthcare centers for them, but only we had 65, and it is not enough for them. So our Turkish doctor has to look after them, and so they have some difficulties. It is hard to find and call refugees for preventive care, vaccinations, cancer screening programs, etc. facilities because they don't have exact address, phone numbers, and even if they have, they are moving all the time. It was a big problem for us in the first years after the war because the refugee people couldn't earn money, couldn't live, couldn't live quickly in a city, and they have to change the city. But now they are more adapted, and they have Turkish identity cards. They have healthcare insurance, so they didn't need to change the city as before. Next, please. And one of my colleagues find all this stuff unfair and says refugees have health services for free indeed. We have more poor people who don't have insurance and can't reach these services. It is true because I had many patients that came to me that with the refugee people, with a Syrian, that please look after me with his insurance. So it is a little bit sad for us. After 50 years on a strict vaccination program, at last we have eradicated some disease like measles and polio, but now we have a huge problem about this disease because we have 3 million guests without vaccination status information. It makes me feel anxious because I have kids too, one concerns. So this is my presentation. Thank you all.
Yeah, thank you, Tuva. Well, yeah, great, Julian. I think we have you already on the screen, so I'll just give you the floor.
Yes. Thank you, Tuba and Andrea. So my name is Julien Artini. I come from France. So I'm a GP in the south of France, in Toulouse. I'm also president of Saint-Exupéry Network, which is the network that promotes international opportunities for GPs, and I'm part of the executive board of VGGM. I'm policy officer there. So I would like to try to present you the health inequity among migrant population in France. So next, please, Andrea. So I don't have any conflict of interest there. Next. So just a little bit of background information in France, so you can understand the type of presentation I will do. The government of France commit to receive the 24,000 migrants in 2015, but 1 year later, they dismantled what we call the jungle of Calais. That was one of the biggest area of gathering of migrants in the north of France. Calais is a little town in the north of France, and that's the last stop if you want to cross to go to the UK. And there was 3,000 migrants. And to deal with those migrants, they opened in 2016 new reception centers across the territory, and primary healthcare professional and team was not ready to do that and to deal with that the needs of that specific population. So I was back then still a resident, and I was in a small town in the countryside, 2 hours from Toulouse, and we saw arriving 30 migrants. And that was really interesting because all the people around me, all the healthcare professionals, all the GPs didn't know really what to do in terms of health and how to deal with all those barriers that prevent us to take care of that population efficiently. So just so you know, there is a little bit of there is 12% of the population that are migrants. And as Andrea said before, what we call migrants is very diverse. So you have economic migrants, people that come from just for studying, and also for poverty reasons, stuff like that. So next presentation, next slide. So because I had that questions, I did a review of literature of the guidelines of migrant care in general practice, because I didn't find the answer on how we have to do things to be efficient in migrant care. So these are the sum up of the results. So there are 6 points. So my presentation will be to present you those 6 points and to see if we are doing well in France. Those 6 points is what we should do. And I will present you in each 6 points if we are doing that or not, and what are the perspective or the issues there. Next, please. So, allowing facilitate primary care access. So, you have to understand that in France, we GPs are in liberal office. So, for the first part, have organizational flexibility. It depends on each office. For example, most of the GPs in France take appointments. So you have to call the office, you have to go to the internet, take the appointment, and that could be really difficult if you don't speak the language, if you don't have a home. And for migrant population, that first line is really hard. And I think in my mind that we failed in France because of the liberal practice. Because I can choose to organize my practice whatever I want, And if I don't try to include migrants in the process, it could be really difficult for them to access. And that is important when you want to assure continuity and stability of care, because if they can access you directly, it's an issue. And I talked about the center before, the center where most of the migrants going are hosted. That type of center, there is no medical support there. So that's just social center. And they have to go to see a GP in liberal practice. And most of the time, they are not staying in that area, and they have to move a lot. So ensuring that continuity of care could be difficult, especially in the countryside. It's more easy when you work in the city. Allowing access to social assistance health coverage. Normally in France, you have universal health coverage. So even if you are an undocumented migrant or documented migrant, you can access healthcare, but sometimes it's really hard to access that type of care because you have to ask that to the administration. So when you don't have any documents, you can access some specific health center that can give you proper healthcare. But after you document it and after you ask for being part of the social security system in France, you have to go to your GPs, you have to go to access all of those things, but the contact with the administrations are sometimes really tricky. So I think that access is not that efficient in France. And it's all goes to the explanation of the system and how we clearly and simply explain the system. And we have big of issue because Tugba said that Turkey is one of the first stop country, not in France. Most of the times migrants that come here we are the second, the third, the fourth stop. So they already dealt with a lot of different systems, a lot of different type of migrant care in the previous country. So it's really difficult to explain them clearly and simply the systems. And of course, encourage the initiative and cooperation with social communities. It depends of whether your GP is interested in that subject or not. Next. You can, yeah. No. You can do it all the way. Okay, so improving the intercultural communication. We also that if when you work with migrants, the biggest barrier is the language. So I found that if we want to do things right, we must use as soon as possible a professional interpreter and avoid the family members and the community. But honestly, we can do that all the time, and that's really, really time consuming, and it's really expensive in France to, when you are in your office, to use a professional interpreter. So luckily, now in France, we have some internet tool, next, like TraducMed. So that's a website that GPs create in France with closed questions. So you can play the questions to the patients and they can answer to you by yes or no. And that's sometimes a tool that can prevent some miscommunication and help you to go through your consultation, even if that's not as efficient as a professional interpreter, but that's something we can do in France. Next. So for integrating the social cultural dimension, we are not trained in France. Health professionals and primary care are not trained to do that, are not trained in general practice. Even nurses or other professionals in primary healthcare are not trained to include those cultural differences. Next. And next. So it depends on the practitioner you consult. And I think the network and the close collaboration with social services depend on how people are trained to do that. And most of the time in France, when you're interested in migrant care, you just have to go with your consultation and learn on the go, and you don't have any type of training to include that directly in your training. Next. So for systematic prevention and screening, we do that a lot, and that's pretty good. Most of the primary healthcare professional knows how to do that. You can do all the slide, Andrea, please. So most of the time, we are quite good at that topics. But when it comes to screening and prevention of addiction and addictive behavior, we failed dramatically at that because, and I will talk about that in the next slide, when talking about health issues, I think it's mental health issues. It's really tricky because to coordinate the care, it's really depending on your network. And even if you're interested in that subject, it's something we failed at in France. So screening and prevent addiction and addictive behavior is one of the worst things. One of the things we don't do really good. And in the same time, the prevention and screening of breast cancer or cervical cancer in women, we have a different type of population in France in migration, and study shows that the second generation, even the second generation of migrants in France, have less screening than the French population. So that's two of the topics that we are not good at in France. Next, please. Support of mental health. So early detection, prevention, rapid recognitions, all of that, we failed, I think, in general practice in France. So if you are a migrant and you have mental health issues, I think that's a big inequalities in access of care because we don't know how to treat that and how to deal with that. Because even if we do the detection, the collaboration after that and the language barrier after that are not efficiently planned here in France to do that properly. And that is, even if you are interested in that subject, even if your office is really flexible in the organization and you have the networks around you, that topic is really hard to do. And I think for me in France, mental health issues among the migrant population is one of the big health inequities we have. So next. Of course, we fail at that. And the last thing you saw on the slide, maintain a positive and stable relationship with patients. It depends of where you are. And I think that lucky factor is not a good way to take care of a specific population. So if you're lucky and you're in a big city and you go to a GP that's used to take care of migrants, you will have an efficient follow-up. But if you are in a different side of the city or in the countryside, that could be not efficient enough. And the last slide is what I found was to make the follow-up better. We have to include migrants and leaders of the communities in research program and in the program to create recommendations. And of course, we failed dramatically at that in France. There is no at my knowledge right now, there is no big research that involve migrants to build guidelines really properly for GPs to use that. Next slide. So we failed, yes. So if I have to sum up that, if you are isolated in France and don't have a community there to help you with the access of care, there is a big inequality there. If you don't have a GP that is used to deal with the community and used to have a network to deal with that, that's a big inequality of access of care. And of course, mental health and screening for chronic diseases are a major setback here. Thank you for your attention.
Thank you, Julian. I think, well, the three of you have presented already, so I think we can pass now to the questions and answer. Now, please, if you have more questions, just type them down. But so far, I have a couple of questions that actually can be, well, answered by the three of you, probably. So I'm going to try to show my screen, and because I have been collecting them. And let me check. Yeah, there it is. Please, Andrea, can you tell me if you are able to see? Because the first questions came just when you were presenting. So, yeah, I think I can give you the floor to any of you. So I don't know if, Andrea, since you have been without presenting, do you want to start with these questions?
Okay.
Yeah.
Yeah, to try to answer to the first question, I think that maybe you are referring to the tool that I mentioned, which is the MIPEX. And well, actually, before I have done this presentation, I didn't know the existence of this index, and it was pretty surprising for me because, as I tried to show in my presentation, from a grassroots perspective of health worker working with most of all irregular migrant, I had a perception that, you know, assistance in Italy was really faulty and lacking. This questionnaire is made up of several parts. Only a part of it is relative to healthcare access, but to be sincere, I read all the items of the healthcare system access, and Italy scored pretty high in each item. If you want my opinion, there is a huge inequality in access for documented and undocumented migrants. So, and this is also to answer to question number 2. When you have to work with the documented migrant, the access is pretty easy because each one of them has more or less the same access of the Italian general population. And the big trouble comes when you have to work with undocumented migrants, because in a theoretical point of view, they should have only access to urgent and essential care, which means basically emergency. But what many Italian regions have done in order to improve the healthcare of undocumented migrant population is to set up ambulatories, which are run normally by volunteers and are financed or through voluntary donations or from the region itself, which run a primary healthcare ambulatory. For example, as I told you, I work in this association in Bologna called SOCOS, in which we have both primary care doctors, but also specialists. And in a few months, we are going also to give odontoiatric service. And how do you manage with minor migrants? Minor documented and regular migrants, they have access to the same level of care of the Italian population. So in case of minor, in Italy, the primary health care is provided by a pediatrician. We call it a free choice pediatrician, which is more or less as a family doctor, but of minors. And minors, of course, have a higher level of security than adults, even if they are undocumented. If you want me to be more specific, I can send you more precise information on it, but you know, I think that up to now it's pretty fine as an answer, or here I am.
Thank you.
And Diana, I also want to answer this question.
Just go ahead, Tubabi.
In our for the first question, in our healthcare centers for refugees, we use the same system that we use for our own people in our primary healthcare services. So we can follow up the babies, we can follow up the pregnant ones, and also we can follow the vaccinations. But as I said before, we only have 65 near all over the country. So if we have enough amount of them, we will have all the information about the migrants. But nowadays it is a little bit less. Thank you.
Yeah, Julian, do you want to have a few words about these questions? Or?
Yeah, yes, just quickly. So for how migrants been measured, I just took that. There is a book edited each year with that's a committee that do research, not research, but yeah, kind of a research on migrant care here in France. So those organizations can be a great asset to measure health on the migrant population. However, I don't have the same result in France for the greater health of the migrant population than the French citizen. And I think because we are not a first stop country, most of the time, we have migrants that come for health issues too. So in that particularly settings, it's really hard to say that there is a greater health than the other population. And for the second question, as in Italy, there is a bigger protection for minor migrants here. So GPs can do the follow-up. We don't have necessarily to do that to pediatrician, but most of the time when there are migrants and infants, they can be followed by pediatrician and in specific centers. So that could be easy for them to get in the healthcare system than adults.
Thank you, Julian. I've seen that Andrea is already answering some question in the chat box, but one of the other questions that came up was how far actually you are collaborating with other healthcare professionals, in the sense that, well, there is it should be interprofessional collaboration, let's say, once you tackle migrants. So can you tell a bit of words about it, if you are working with other professionals or not in your daily practice? Maybe Andrea can start again.
Yeah. Okay. This is a paramount question. For example, if I have to mention my working at SOCOS, SOCOS is an ambulatory which is made up, as I told you, of different professions. I guess that right now we have kind of 10 or 11 specialists and GPs working in the same place. And I think that working in team would be paramount. For example, also having a nurse would be important, but still we are actually utilizing the same approach that we use in general primary care, which is a referral and contra-referral system. And in these cases, which are often complex because we are working with people living in very unstable situation, homeless people, and so on. It would be very, very nice to have the possibility to work in an integrated and really multi-professional way, and conducting, for example, multi-professional visits at the same time. But actually, we didn't get there yet. So the huge part of the work is done alone through the help of nurses and other specialists, but through a referral normal system.
I think.
Oh,
Go ahead,
also,
Chuba.
it is. Sorry, Julian. Also, it is same in Turkey. We don't have a team system. We have to deal with them in primary care, and then we will refer them to the secondary care system.
So in France, you don't have an integrated healthcare system to team system, but now I work in Toulouse in the city center, so it's easier for me because there are a specific center for undocumented migrants, and also with the hospital there are some specialists that are used to the questions. So we work as a team, but with referral. And we work with association too. Association is a big part of the extended team. We are not in the same place, and there is no coordination there. But we can call them, and they can be great part of the healthcare system for migrants.
Thank you, the three of you. I think you have posted some things on the chat box, especially because they were asking maybe in what were the project that you were talking about during the presentation. So that is there if someone is interested. I don't see more questions actually, but it's fine. It's okay. I think it was really interesting, and I see there's like a lot of common threads, and common challenges that we have, but also like more specific country ones. I just want to show these final slides, basically to say, well, a bit of words of the UFPC, because this webinar comes as a consequence of the conference that we will have in, let me see where it is, the conference that we will have in Nanterre this year in one of the suburbs in Paris. And well, we want to welcome you also here because it's going to be about primary care and local communities, and we are going to be talking about health equity for everyone everywhere. So it really fits in the topic, this webinar, and it's one of the hopefully two that we will have along the year. So well, we will announce the next webinar, but mainly I wanted to thank you, the three of you, because it has been really interesting webinar, and I think not every day you have three different perspectives and three different countries together presenting what is happening in each place. So thank you so much. But anyhow, thank you also to the attendees. Also, if you have any question, you can actually send it to us to info@euprimarycare.org. And I think they will be happy to answer you any further questions. So if you have any idea, feedback, and so on, they will be also very welcome. And yeah, I just want to remind you about the conference. The call for abstract is open until the 1st of May. So any abstract, more than welcome. If you are working in any project that fits in the topic of the conference, which is about health equity, it will be more than welcome. And just thank you, everyone, and especially thank you to the three of you.
Thank you, attendees, too.
Thank you to everyone. Yes.
Thank you.
Thank you, everyone.
Bye-bye.
Bye.